Okay, wonderful students. Now we're going to discuss a really important chapter, loss, grief, and dying. The potential for loss, grief, and death exists at any and every stage of life, including right after birth. This is true for people experiencing altered health and for members of their family. Death may be as difficult for healthcare professionals as it is for surviving family members. The goals of nursing include promoting a respectful and peaceful death through compassionate palliative care and facilitating the patient's and family's coping with the patient's disability and their death. Here are the learning objectives for this chapter. Please take a moment to review each one of these. If you can speak to these and apply these to your nursing practice, then you have accomplished your learning for this chapter. Here are the different types of losses and the responses to the loss. They're important to understand for facilitation of interventions for coping as well as adaptation. Loss occurs when a valued person, object, or situation changes or becomes inaccessible and the value is diminished or removed. Actual loss can be recognized by others as well as by the person who is sustaining the loss. For example, it could be a loss of a limb, it could be a loss of a child, a valued object such as money, or it could be a loss of a job, right? Perceived loss, such as loss of youth, maybe loss of financial like perceived loss of financial independence, perceived loss of a valued environment. How many of us have ever wondered, man, I wish it used to be the way it was when so-and-so was my boss, right? It could be a perceived loss that's totally intangible to other people, right? It's just tangible to that person, right? Directly related to actual and perceived losses are physical and psychological loss. A person who loses an arm in an automobile crash suffers from both the physical loss of the arm and the psychological loss that may be caused by an altered self-image or the inability to return to his or her occupation or other activities that they are used to doing. These losses are simultaneously physical, psychological, and actual. A person who is scarred but does not lose a limb may suffer a perceived and psychological loss of self-image. Maturational loss is experienced as development occurs, such as loss of one's youth, or anticipatory loss occurs when grief behaviors begin before a loss has actually taken place. This can happen when a family is dealing with one of its own members diagnosed with a terminal illness, like when my father found out in 2000 that he was dying from terminal cancer. Engel's stages of grieving theory describes these steps in this proper sequential order. The first stage is denial of the loss and refusal to accept the fact that the loss has actually occurred. This occurs during the shock and disbelief stage. Shortly after the refusal to accept the loss is in shock and disbelief is a stunned or numb response. During the developing awareness stage of this theory, physical and emotional responses such as anger or feeling empty or crying that would occur. In the restitutional stage, they often perform spiritual and cultural rituals during this stage, including social expressions of mourning, such as funeral services. The restitution stage is dealing with the void left by the loss. The idealization stage involves the exaggeration of the good qualities of the person or object, followed by acceptance of the loss and a lessened need to focus on it. And then the final stage of Engel's theory is the outcome phase, during which time coping and adjustment to the loss occur. So make sure you know these 6 stages of grief, okay? It's important. I would look at your book. They have good information in there. Okay, so definitions. Grief is an internal emotion reaction to the loss. Dysfunctional grief is when there is abnormal or maybe an abhorrent or an extreme response to a loss. Okay, so that's dysfunctional grief. Bereavement is a state of grieving from loss of the loved one, right? So it's that person going through the grieving of that loss of that loved one. And then mourning is the actions and expressions of grief. So that they could include like symbols, ceremonies, outward expressions of grief, right? The accurate definition of death has proven difficult over time as technologies advances such as cardiopulmonary resuscitation have been able to restore lost functions and I quote, bring back a person to life, right? The Uniform Determination of Death Act provides a legal definition of death. The medical criteria used to certify a death are cessation of breathing, no response to deep, painful stimuli, lack of reflexes like gag or corneal, and lack of spontaneous movement, flat encephalogram, so no brain waves basically, heart-lung death, cessation of no respirations, no circulation, so there'll be no audible blood pressure, we don't feel a pulse, no apical pulse, those kinds of things. Typically, two nurses, RNs and LPNs, can pronounce this death. And we actually, when a patient is on hospice in Arizona, one nurse can pronounce a death if they're on hospice. Okay, what makes up components of a good death? So a good death is one that allows a person to die on his or her own terms, relatively free of pain, relatively free of anxiety, and with dignity. It is free from avoiding distress and suffering for patients, families, and caregivers. So they should not have any distress, they shouldn't have any suffering. That includes the patients, families, caregivers, anybody around the patient, right? In general, the death should be in accordance with the patient's and family's wishes, right? With patient being the priority. And it should be reasonably consistent with clinical, cultural, and ethical standards that we use for care. Characteristics will vary among individuals, but it's important to respect the individual's wishes above all. If you are unaware of them, sometimes you have to rely on family for guidance in this area, especially if the patient signs on to hospice really late, like the patient's already, in the active stage of dying. And so they're not talking, and therefore you got to get the information from the family. If, however, the patient is alert and oriented, then you get their wishes from them, right? During end of life, the family is very much your patient as well, though, and you will support them as much when the patient's alive and, of course, more after they're gone, right? But once again, that being said, the patient's death is theirs to determine the course. And it is our job to use resources like our chaplains, social workers, everybody, right? To reach the patient's end-of-life goals, really. Clinical signs of impending death. As death nears, the patient may have a decreased level of consciousness or may have agitated delirium. It could go either way, right? Although decreased consciousness and or agitation are both normal at end of life, they are very distressing to the patient's family. It is important for nurses to prepare family members when death is imminent and to determine if they are more comfortable being alone with a dying loved one, or are they more comfortable being supported by a nurse or other members of the healthcare team, right? The list of clinical signs of impending death are listed here. You do need to know these. There is a slide in the PowerPoint, and I will be handing it out in class as well, that goes over the different clinical signs and symptoms based on time frames. You need to know that as well. And be aware of it, because whether you choose to work at end of life, you're going to have patients who die in other nursing roles. You will encounter a dying patient at some time. I used to, in the ICU all the time, right? So not all the time, but it did happen, right? And so it's important that you know what those signs and symptoms are. So pause the video and start making your note cards, okay? Providing care to facilitate a good death. So we are, this is definitely guided, again, by the values and preferences of the patient themselves and the family too, right? We're going to find out exactly what they consider a good death, and we're going to do everything in our power to make that happen, right? Again, the patient is going to be able to make their own independent decisions, and we are going to provide dignity through the entire last second of their life. We're going to give control back to the patient, allowing them exactly how we're going to manage their signs and symptoms of their disease and the progression of their deterioration, right? And we're going to focus on relieving any kind of signs and symptoms of pain, anxiety, and fear, right? We're going to address all of those. We're going to prepare the patient to die peacefully. We want to give the patient an opportunity to have discussions about their life and give them an opportunity to have a sense of completion of one's life and of making a difference in one's life. And it's important that they have a good relationship with everybody on the healthcare team as well as the family, right? Kubler-Ross's 5 stages of grief. Okay, so you even need to know this one better than the Engler one. Okay, so the Engler one, you need to have a bigger, have an idea about it, but this one you really need to know well. Kubler-Ross's 5 stages of grief. This theory is perhaps the most popular of all theories and conceptual frameworks relating to grief and loss. This theory has 5 stages in this sequential order. The stages of dying, much like the stages of grief, may overlap, and the duration of any stage may range from as little as a few hours to as long as months. And like I said with my mom, years, right? Although hers was complicated grieving, right? The process varies from person to person. Some people may be in one stage for such a short time that it seems like they skipped that stage, right? Because they were only in there for a short time. Sometimes a person returns to a previous stage, right? It's not always consecutive. They'll go through denial and isolation and then anger, and then they'll back down to denial, right? And some may even begin in a later stage, for example, anger. Some may skip right over denial and isolation and go right to anger or bargaining, right? I've seen it happen with both. And then they may move through the other stages randomly, just, here, there, hit or miss, right? So knowing that each person is an individual and thus their personal experience with the stages of grief may differ than those of previous patients and family members you've cared for is an important concept. Kubler-Ross's stages of grieving are similar to other theories in terms of denial, anger, depression, and acceptance. The bargaining stage, however, is unique to Kubler-Ross's stages of grieving. In this context, bargaining entails the patient's negotiation with their maker or higher power to delay their inevitable death. For example, they may pray to their God or higher being to let them live long enough to be able to participate in a major event like the birth of a grandchild or the graduation of a child or maybe the wedding of a child, right? I think, husband of a terminally ill patient begins the grieving process. Okay. So I think this is the hardest part of caring for a patient at end of life. The family's grief is rough, and it is so important to be there for them and the support of them. Even if you are just a calm presence or a hand on a shoulder, just to let them know you are there to support them in whatever they need to grieve. Because everyone grieves differently. Don't make judgments, just try to support them. Be a calming presence. The best thing you can do as a nurse at this time is to be helpful and compassionate. I always treat my patients and my patients' families just like I would want my family member to be treated. During end of life, this is no different, right? Okay, so palliative and hospice care, they are different, right? Palliative provides quality of care, so people live with and not suffer from a disease process. It is used throughout the entire disease trajectory, right? And what we do with palliative care is we manage the side effects of the disease, or maybe even the side effects of the treatment itself, right? So again, our goal with palliative care is to ensure that we are treating the disease process so that the patient doesn't suffer from that disease process, and to treat the disease process so we improve that patient's quality of life, right? Hospice is different because it's for, first of all, it's for terminally ill patients. Hospice is. They typically have 6 months or less of life expectancy. It is a requirement for hospice. Now, please be aware that if a patient signs on to hospice and they have 6 months or less, once we start managing that patient's, we reconcile their meds, we get rid of, at least half of their meds that they're on that they didn't even need to be on, right, any longer. Yes, they needed them initially when they were put on them when they were younger, but now at their advanced stage or whatever's happening with them, they no longer need those meds. So guess what? We take them off those meds, and they actually, for a short time frame, do better, right? So what I'm trying to say in the long run is, if a patient lives longer than 6 months, all we have to do is reevaluate them, in that 7th month or whatever it is, to see if they still are eligible for hospice care. The criteria is, at their current evaluation period, if they're 6 months or less, they can sign on again. So even if they live longer than the 6 months, we can recertify them for hospice. But for hospice care, it needs to be 6 months or less. Palliative, though, is for everyone from the time they get diagnosed with a severe illness or disease, right? Like CHF, COPD, whatever that looks like, lupus, whatever, and the care of that patient. So the other aspect of hospice that is different is it focuses on only on the quality of life and not extending life, right? So for hospice, we're not going to do aggressive treatment type care. It's a pathway of providing a good death by focusing on the pain and anxiety management at end of life, and dealing with, coping mechanisms, and dealing with reality, what's happening with the patient, right? And focusing on having the rest of the time that they're left on earth, having quality time, right? Enjoying their life. And palliative care is really more about managing the disease and managing the side effects of the treatment, right? And trying to give you the best life that you can while extending it, palliative wise. And hospice literally means, look, we're not doing any aggressive treatments. We're going to simply provide, for the time that's left, we're going to provide a good time left on earth by focusing on pain, anxiety, and management, right? Advanced directives are really critical components that should not just be addressed at old age. We should all be putting our advanced directives into place just in case something happens, because we know there are people who die every day from car accidents and other things that are unexpected, right? So at any age, a medical crisis could leave you even too ill to make your own healthcare decisions. So you really need to encourage your patients, as well as yourselves, to get your advanced directives written down and officially filed, right? If you are not sick now, planning for healthcare in the future is an important step toward making sure that you get the medical care you would want if you were unable to speak for yourself, and doctors and family members will be making decisions for you, right? So unless you want to leave your end of life decisions, or even just not even necessarily end of life decisions, but how you want to be treated medically. Do you want to be put on a vent? Do you want to be CPR to be initiated? Do you want to receive IV fluids? All of those kinds of things, right, could be put in advanced directives. And again, it really doesn't matter what age the patient is. A medical crisis can truly happen at any time. And an advanced directive is a legal document that goes into effect only if the patient is incapacitated and unable to speak for themselves, right? Otherwise, if the patient's alert and oriented and talking, we go with what they say. When they're no longer able to do that, then we go by their advanced directive. So this is the way that you can make sure that your family does not try to, once you're unconscious, do whatever they can to extend your life if that's not what you want, right? Because an advanced directive makes sure that your goals are kept, that your goals are what we do, right? The patient's goals. Again, it could be a result of disease or severe injury, right? And could happen at any time. It's just a document. It's a document that helps others know what to do and what type of medical care the patient will want if they're not able to verbally tell us themselves. So again, it includes things like CPR, cardiopulmonary resuscitation, ventilator use, artificial nutrition, artificial hydration, comfort care measures, all of those things, right? Special orders. So to prevent the improper use of cardiopulmonary resuscitation, which of course is designed to prevent unexpected death, right? Some healthcare providers write do not resuscitate order, or a DNR order, or a no-code order. And what this is a document that literally says, I do not want to be resuscitated in the event that my heart stops, okay? So if the patient lives at home and has a DNR, or do not resuscitate order, it's usually filled out on an orange form, and it's put on the refrigerator, right? Just in case if somebody were to call 911 at end of life, or whatever that looks like, and the paramedics show up to the home, if the patient has that orange form on the fridge, then the paramedics won't do CPR. That is the only time they won't. If that's missing, they're going to do CPR, okay? So a do not resuscitate order means that no attempts are to be made to resuscitate a patient whose breathing or heart stops. We have the policy in the acute care setting, so hospitals. And again, it must be written by a physician and entered by a physician. We as nurses cannot take this order verbally or over the form. Again, it must be by a physician only. However, please go in with your doctors when they are having these conversations with your patients, as many doctors are just not very good at having these types of conversations, and they will completely support, appreciate your support being there for these conversations, right? It's important to note that in hospice care settings, the RNs are typically the individuals that will get these orders and enter them into the computer. So while in the hospital we don't get them, hospice nurses do get them, or hospice social workers too will get them. And in hospice, the doctor still has to write the order, but it's nurses or social workers that will initiate the conversations and will enter the order in the patient's chart, and then send it to the doctor to sign. Terminal weaning is the gradual withdrawal of mechanical ventilation from a patient with a terminal illness or an irreversible condition with poor prognosis. It is important to distinguish the voluntary act of a patient who is still capable of eating, drinking, making the decision to refuse food and fluids from, refusing to consume food and fluids from the natural anorexia, as well as the loss of the thirst mechanism. that frequently accompanies, the end stages of dying, right? So as our body starts to shut down and starts to die, it naturally has this natural anorexia and loss of thirst because you don't want to put food into a dying body. So the body knows that and it shuts down, right? And you don't get the hunger pains or the thirst mechanism or any of that. While some consider refusal of food and fluid to be a form of suicide, others view this as a decision to forego life-sustaining treatment. So you can see how some could think volunteering stop eating and drinking is committing suicide, while others believe that no, it's just honoring their wishes of not doing advanced life measures, right? Let's see. Remember that honoring this preference requires the support of the family, the physician, the healthcare team, everybody that's involved in the dying process. So if a patient were to bring up this voluntary cessation of eating and drinking, it's important that you have a conversation with the entire team. And it's important to note that as the body begins to decline and at end of life, it no longer needs food or fluids as the organs are beginning to shut down. Again, if you were to push food or fluids during this time, it can cause a patient to go into severe distress and respiratory problems, and deal with extreme pain and extreme shortness of breath at end of life. So it's important we have those conversations with families when they insist on us putting an IV in somebody who's actively dying to hydrate them, right? They need education, they need support, and that's what we're there for. Refusing food and drink is one of the symptoms, again, of the natural dying process and not its cause. Getting people and family to understand that is challenging at times, but it just takes time and patience and having conversations that, us not giving them food and water is not causing their death, but it's the cancer or whatever the chronic illness they have that's killing them, and their body shutting down and no longer needs food and water, right? Side effects of dehydration include thirst, dry mouth, both of which can be alleviated by providing frequent and thorough mouth care. So we teach patients and family members about that, keeping the patient comfortable. So when the body doesn't get food and fluid and it starts to shut down, the only, the mechanism that does kick in, the thirst and dry mouth, we can alleviate that by getting the toothettes. They're little tiny toothettes that you dip in water, and you provide mouth care to the patient, and it relinquishes these side effects, which is really neat. For the majority of people, food and fluids do not increase the quality or quantity of life. In fact, again, forcing someone to eat or drink at end of life may cause pain and or severe discomfort, including shortness of breath, bloating, gas, nausea, vomiting, diarrhea. I can't stress it enough, right? Additionally, the muscles used to chew and swallow become weak at the end of life, causing difficulty swallowing and possibly causing the patient to choke and aspirate the food or fluid, which just complicates the patient's care. So you really don't want to encourage that when it's truly actively dying patients. Active euthanasia is taking specific steps to cause a patient's death, while passive euthanasia is defined as withdrawing medical treatment with the intention of causing the patient's death. And then palliative sedation is the lowering of patients' consciousness using medication for the express purpose of limiting patients' awareness of suffering that is intractable and intolerable. So we had a patient who had a left breast tumor extrusion. So there was a tumor in this patient. She was 48 years old when she was diagnosed, and she had cancer that had started in her left breast many, many years before and had metastasized throughout her entire body before she was diagnosed with it. And the tumor ended up growing all the way outside, breaking through her skin and causing a tumor extrusion that was extremely painful. We had this poor lady on so many medications, and still her pain got to a point where it was intractable and intolerable, meaning unmanageable, like we couldn't touch it. Okay, so she opted to have palliative sedation at end of life with us, and we made her comfortable, so she wasn't aware of her suffering. Okay, medical examiners cases or coroner cases. So if a patient dies within 24 hours after occurring any unusual circumstances, like they fell or they hit their head or they were in a car accident, abuse, neglect, overdose, any of these, right? It will result in the medical examiner for that state taking that patient's body and doing it in a medical examiner or coroner's case with them. And so, again, surgery, if they die within 24 hours of surgery or invasive procedures. This includes hospice patients. So, even with hospice patients, if they have an unexpected death within 24 hours of any of those situations I discussed, we have to call the medical examiner's office, the hospice nurse, and have a conversation with the ME surrounding the patient's care. They will ask for the last 3 months of medical records, and I mean every single day's nursing notes and all of that. So we have to fax all that information over to the ME's office. They'll look at the case. If they feel that there is any chance that the patient's death is related to the fall, the surgery, the abuse, the neglect, the overdose, or suicide even, they will take the patient's body and do a full autopsy to determine if it was in fact the hospice diagnoses that killed the patient, or was it in fact due to the car accident, due to whatever else, right? But if they look through the nursing notes that we've faxed over and determine that the death was in fact due to their terminal illness and not the accident, surgery, whatever, then they'll decline the patient's body, and then the mortuary can come pick up the patient. So that's another piece that is part of the hospice nurse's responsibility, and also it is our responsibility in the hospital, right? So again, if we have an acute patient in the hospital who within the last 24 hours has any of these things happen, then we call the ME's office as well. They'll take the case, we'll get our documentation to them, and then it goes from there. All right. Many factors, including age, family relationships, socioeconomic position, cultural influences, religious influences, all of these things affect a person's reaction to death as well as how they express their grief. Like the stages of grief reaction, these factors vary from person to person. The factors listed on this slide may affect the nature, the intensity, or the duration of the grief. You know, it's important to know that children, they don't understand death on the same level that adults do, but their sense of loss is just as great. And I think it's important to know that hospice companies, especially larger ones, have really specific bereavement groups for children that are wonderful and that I would highly recommend. Hospice of the Valley has a great one. And it's groups where they meet with other teenagers and children to discuss, loss. And it's led by a professional that's been trained specifically with children and teenagers and how to deal with and cope with grief. Family rules have an important effect on a person's reaction to and their expressions of grief. A bereaved family may suffer more acutely if there is no health or life insurance or pension after the death of a family provider. Such families face not only the loss of their loved one, but also an economic loss that may further disrupt their family life, right? Cultural influences a person's expression of grief. In many families in the Western culture, grief is a private matter that should be shared only with the family. As such, many people internalize their feelings of grief and may not express their feelings of loss to others. On the other hand, cultural background may necessitate that the patient and family's public display by emotional and distress with loud weeping and moaning. Cause of death can have some effect, such as sudden death may induce shock along with normal grief. I will tell you though, no matter how someone dies, if it is unexpected, the grief is no different. Family or loved ones are never truly prepared for the actual death and the changes that will come after the person is gone if it's unexpected. Suicide prevention. So things that we look at when we're looking at suicide is, do they have access? Do they have a genuine access to be able to commit suicide if given the opportunity? It's really important that we listen actively to our patients. We need to reassure them and give them accurate information. We have to encourage professional help. If there is a desire with or without a plan, it is a medical emergency. Let me repeat that. If there is a suicidal desire, whether the patient has a plan or not, this is a medical emergency that you must get everyone immediately involved. Okay, and we're definitely going to encourage self-help and supportive strategies. We're going to provide them with all of that information. Our social workers are great at that. And we're going to always use our geriatric depression scales for our older adults to assess their risk, right? Okay, needs of dying patients. Again, your book has very, very good information on the dying person's Bill of Rights. So take a look at that. Comfort care is an essential part of medical care at end of life. It is the care that helps or soothes a person who is dying. The goals are to prevent or relieve suffering as much as possible and to improve quality of life while respecting the dying person's wishes. Physiological needs include pain and anxiety management, hygiene, and we've already discussed their nutritional needs. Pain is a big one though, so be sure you are assessing this patient very, very frequently for pain. I check my end-of-life patients a minimum of every hour, depending on the stage of dying, and if they're actively dying, I'm usually in the room with them. Or at least checking on them every 30 minutes. Hygiene is a big one too. For comfort reasons, please keep your patients clean. Take extra steps to turn them, manipulate their muscles. Remember, they're going to be sore, just like anybody who lays around, right? You're going to get sore. A fear of isolation is a real thing for our end-of-life patients. Having to face death alone is a scary thought and is a primary concern of dying patients. So we are definitely going to support these patients, and we're going to tell them we're going to be present, we're going to give our full attention, and we're going to show them that we genuinely care, right? And you know what's cool is we actually get to do it. That's what's so wonderful about hospice care. We're definitely going to encourage the presence of family members in the room and sharing and reminiscing about their lives when the patient's actively dying. Patients, remember that their hearing is the last thing to go. They can hear, even though they can't communicate, they can hear their families and the nurses and everybody talking in the room, right? Because it is the last sense to go. And it's the first sense, by the way, to come back if you're post-op, right? Or anywhere, right? There is also a national volunteer program that provides companionship and support to people who are dying alone so that no patient dies alone. So we will call and reach out to these individuals because they provide this wonderful component to end of life care. And then we're usually there with them as well. Encourage the family to talk to the patient again, even if they are not conscious, because the hearing's a lost to go, they most definitely can hear the patient, family members talking. Always speak to your patients too, whether they can speak to you or not, because again, they can hear you, whether they can communicate or not, right? Let them know what you're doing, how you're caring for them, and give them words of comfort, right? Chances are they can hear you. We always take turns with sitting with our dying patients on my unit, and excuse me. We don't want them to be alone, right? Needs for intimacy. When patients' loved ones are present, give them time alone so that they may have the intimacy they need, right? So they can have the conversations they need to have. They need to have their private time, right? Although not all patients follow specific spiritual or religious beliefs, most require some form of spiritual care, right? So make sure we're meeting those needs as well. Many terminally ill patients find great comfort in the support they receive from the religious faith. Help obtain these resources of clergy, pastoral care, as situations indicate. Most patients need to feel that their lives have meaning. Many feel a need for hope in the face of death. And that's okay, right? Be present and support them at each and every step of the way. Okay, this is the slide that you really need to know, and I mean like really need to know it. So pause the slide and make flashcards for these 3 different stages of dying. 1 to 3 months before death, you'll start to see the patient begin to withdraw from the world. They'll literally start to separate themselves from the family. When my dad was dying, when he found out in 2000 he was dying, about 3 months before he died, he started alienating himself from the family. He, like when we got together at my house for a pool party with my entire family. And about an hour into the pool party, my dad went inside my home and started watching TV. It's their way of trying to get the family members who are left on earth to start to deal with them not being around is part of it, right? 1 to 3 months before death, sleep increases. They have difficulty the body starts having problems digesting food. Their appetite and food intake starts to decrease. They start to prefer liquids over food. The anorexia that naturally produces from the less food intake, it produces ketones and ketosis, pain, and an increased sense of well-being. 1 to 2 weeks before death, you'll have the cardiovascular system starts to deteriorate, and you start to see a drop in the patient's blood pressure. They'll also have yellowing, pallor start beginning in the skin that will get worse over time. Their temperature fluctuates. So at times they'll be extremely hot, well, they'll perspire, and then other times they'll be cold where they're covering up. Respiratory rate will fluctuate. Again, at times they'll be above 20 breaths per minute, and other times they'll be 10, 12 breaths per minute. You might start to see the beginning of sleep apnea, and they start to have congestion in their chest or that rattling sound. At this point, it's just intermittent and random, right? So that congestion starts to begin intermittently. And then days to hours before death, you get a surge of energy right at the end, right? And sometimes this will provide false hope to some family members who either haven't accepted that the patient's dying, or it literally just gives them false hope because all of a sudden, they had been in this kind of sleeping 22, 24 hours a day, 23 hours a day, right? And then all of a sudden they're alert and oriented and engaging and eating and all of these things. And the patient's family members think, oh my God, they're gonna live, but that's not the case. It's just this surge of energy and mental clarity right before they're going to die, right? So it's important to have those conversations with the family. So during this surge of energy, they talk and eat with their family and they converse. I'll tell you about an example in class when we talk about end of life. After this episode, though, they become dehydrated. They're unable to swallow because the muscles in the back of their throat stop working. The blood volume diminishes. Their tissues of their tongue sag. Their gag reflex declines. They get increased secretions because they can't clear their throat, right? But the good thing is it's not bothering them because they're not alert. It does, though, bother the family because the congestion or rattling now becomes pretty constant. And so we have to teach them tricks like tilting the patient's head and putting a towel down, on the side of their face for the secretions to drain out if the secretions bother them. We try to educate the patient's family that it doesn't bother the patient, not to worry about it, but if it does, they can sit the patient up and turn their head to the side, and then they won't hear them as much, if at all. Just because they can't swallow, they can still absorb the morphine, liquid morphine, again, if we put it under their tongue or in the buccal space, then, or buccal, however you pronounce that, then they can get that med still in their body. They don't need to swallow it, right? The mucosa will absorb it. So their mucous membranes tend to dry up. So this is important to educate your family on keeping the patient's lips moist with lip balm. It's important to educate that the patient will have rapid shallow breathing. They may even experience Cheney-Stokes respirations. They'll become clammy because their peripheral circulation has decreased. Remember, the core of the body is going to provide itself with blood before the periphery does. So at end of life, all the blood goes to the core, and their peripheral limbs, like their feet and arms and hands, get clammy, cold and clammy, right? Kidney functioning declines, so their urine output will steadily go down and then totally stop. Same thing with peristalsis and processing of food, so they end up being constipated and then the bowel stop. They don't produce any more bowel movements right at end of life. Vision blurs. Again, the rattling sound will be heard continuously. And it's very important to know that restlessness and agitation is common at end of life, so we pre-medicate for that to keep the patient comfortable, right? So we do lots of education on that as well. Again, trusting nurse-patient relationship is huge, right? Patients must be allowed to go through the stages of grieving and be supported in their decision-making, right? That's our goal, and that's our job as the nurse. Competent patients have the right to consent to or refuse any and all indicated medical treatments, right? Even life-sustaining treatments, and should be made aware that it is their right to make these choices, right? With the patient's permission, we want to encourage the family and significant others of the terminally ill patients to participate in planning the patient's care. Healthcare personnel should be available to discuss the patient's condition with family members and should support and offer support and care to the family as the grieving process continues, right? We want to encourage the patient's family members to participate in the patient's end-of-life care, right? Because this will help them deal with the grieving process, right? Nurses assist the patients and loved ones with the grieving process and with coping with suffering, grief, loss, death, bereavement. As with all other nurse-patient relationships, the nurse initiates the relationship by establishing trust with the patient and then encouraging the person to vent their feelings in a trusting and supportive and non-judgmental environment. The nurse also assists patients and loved ones in terms of their coping with grief and loss by encouraging them to learn about and employ effective coping strategies. Nurses make referrals for patients for community resources. We make Referrals might include psychological, social, religious, spiritual groups, maybe counselings, could be family therapy, group therapy, could be support groups in communities. It could be things to help prevent complicated grieving. Most people think of grief as something that happens after a loved one dies, but grieving really can occur before death, right? And it does. It starts to occur at the onset of the notification of the terminal illness, right? This experience is known as anticipatory grief because it occurs in anticipation of a death or some other type of loss, right? Like the loss of abilities or loss of independence. The term anticipatory grief is most often used when discussing families of dying persons, although dying individuals themselves can experience anticipatory grief as well, right? It includes many of the same symptoms of grief after loss. It has been defined as the total set of cognitive, affective, cultural, and social reactions to expected death felt by the patient and or family, friends, coworkers, peers, etc. Anticipatory grief have been identified among survivors of depression, among people adjusting to the consequences of death. Anticipatory grief provides family members with time to gradually absorb the reality of the loss. Individuals are able to complete unfinished business with the dying person. For example, saying goodbye, or I love you, or I forgive you. That's a big one. Anticipatory grief may not always occur. Anticipatory grief does not mean that before the death, a person feels the same kind of grief as the grief felt after a death. There is not a set amount of grief that a person will feel. It varies from person to person. The grief experience before a death does not make the grief after the death last a shorter amount of time or not be as intense necessarily. Grief that follows an unplanned death is different from anticipatory grief. Unplanned loss may overwhelm the coping abilities of a person, making normal functioning impossible. Mourners may not be able to realize the total impact of their loss until much later on in life. Even though the person recognizes that the loss has occurred, he or she may not be able to accept the loss mentally or emotionally. Following an unexpected death, the mourner may feel that the world no longer has order and doesn't make sense to them. Complicated grief is like being in an ongoing, heightened state of mourning that keeps you from healing. And it's just continual and ongoing in a vicious cycle. Signs and symptoms of complicated grief may include intense sorrow, pain, and rumination over the loss of the loved one. Focus on little else but the loved one's death. Signs and symptoms of complicated grief are similar to normal grief. However, symptoms fade with time with normal grief, but people with complicated grief experience them way more intensely and persistently. Some signs to look out for include excessively avoiding reminders of their loss, obsessively thinking about their loss, intense longing for a person who has died, feeling a sense of loss or purpose in life, excessively seeking proximity to reminders of things that remind them of the person they've lost, could include suicidal thoughts, being unable to accept that the loss has occurred. Symptoms of complicated grief can and does manifest physically in people. Like, for example, loss of appetite, insomnia, stress, weakened immune function, all of these things, right? And for example, when my dad died in 2000, my mother for 10 years went through complicated grief. She was still mourning the loss of my dad on year 9 as intensely as she did the day he died, or actually the day we found out he had terminal cancer. Treatment of complicated grief focuses on helping people living with the condition to begin their healing process. Bereavement therapy is most commonly used as a treatment option for this condition. Where complicated grief evolves or is accompanied by another mental health condition, it is also important to treat this condition. For instance, where it's accompanied by depression, antidepressants might also help to relieve symptoms of complicated grief. It did for my mom. A bereavement counselor will encourage the patient's family members to monitor their grief to gain a better understanding of where they are emotionally at the time. They'll be encouraged to join a bereavement support group, which helps patients' family members cope with feelings of loss and sadness. Learning that they are not alone and that there are people who can understand and experience the feelings that they are experiencing makes them feel like they're being heard. They might also be encouraged to see a psychodynamic therapist. This therapist may help them identify past losses and their connection to their current loss. Traumatic grief therapy is another treatment option that has proven to be effective for complicated grief. With traumatic grief therapy, the therapist uses behavioral methods and interpersonal techniques to help them overcome their loss. And again, they utilize medications as well as therapy, right? Talk therapy and other different types of therapy, maybe CBT or cognitive therapy. Any kind of things that can help with the complicated grief, right? Okay, providing postmortem care is definitely part of nursing responsibilities that you will definitely do. Postmortem care serves several purposes, including preparing the patient for viewing by the family, ensuring proper identification of the patient prior to transporting them to the morgue or the mortuary, providing appropriate disposition of the patient's belongings, maintaining vital organs if donation is planned, right? That's a planned process, by the way. It ensures government regulations at both the state and federal levels that we are required to do at the hospital to certify the patient's death, basically. It also helps to identify potential donors and to care for the body after death, right? In the acute care setting, most facilities will utilize a two-nurse pronunciation of death, and then the physician is notified and gives us the order for the death. And then the physician will sign the death certificate. So, two nurses verify death at bedside. We listen to the heart and lung sounds independently for a minimum of 2 to 5 minutes before pronouncing death. An organ donation is contacted for every death immediately in the acute care setting. And it's important to note that in hospice care, only one RN or nurse is needed to pronounce death. Then we notify the doctor, who again will sign the death certificate. Excuse me. Postmortem care of the body. Okay, an autopsy may be requested by the medical power of attorney and may be done for, again, an unexpected death, depending on the circumstances. We talked about that previously. If death is caused by an accident, suicide, homicide, overdose, illegal therapy, post-op, all of that, right? Then again, we'll contact the medical examiner's office or coroner, and the coroner will then decide whether or not to accept the body for a full autopsy or go ahead and release that body to the mortuary for the mortuary to pick up. Excuse me. In preparing the body for autopsy, sorry about that, I was choking. If preparing the body for autopsy, the body must be left as is. And I mean like literally as is. No cleaning, no removal of any lines, no removal of any Foleys, nothing. You send it exactly as is to the ME's office. Otherwise, if the patient does not go to the ME's office, then we do clean the body up. We clean around all the lines. Again, we leave all of the lines in place. We just clamp the lines. We may place a bag over the lines in drains and Foley so that the family doesn't have to see it, but we leave them all in place, right? And we keep the body covered in the hospital gown, or we put on the clothes that the patient's family has picked out if they like us to. We put the body in the correct anatomical position with their eyes closed in a peaceful look with their hands folded across their chest, okay? We just want to make the patient look presentable to the family. We keep the patient in the room until family has, we keep the patient's body in the room until the family has time to come and spend time with the family. And then what we do is we'll request a body bag and identification tags, and then we place the body in the body bag, put the identification tags on them, and then we send the body down to the morgue. And then call the mortuary to pick up the body. Please note that we will allow family to clean the body if they request it. Some cultures and some religious groups prefer to do this. And really, in some cultures, they insist upon it. And it's important to note that some cultures and religions require that the body be buried within 24 hours. So this includes Jewish, Muslims, and Islam. So again, Islam, Muslims, and Jewish, they need to be buried within 24 hours. So it gets challenging at times, as you can imagine, if we need to get paperwork and things to the medical examiner's office to see if they're going to accept the body of these families, right? So we got to work quickly. And unfortunately, there are times when an ME's office will have to take the body of a patient who died unexpectedly, that's Islam, Muslim, or Jewish, and do an autopsy, and they're not able to bury the body within 24 hours. So that does happen. It's unfortunate, but it is mandated on some cases. Okay, last slide. We always support the family after death. The family is allowed to spend as much time as needed in the room with the patient after death. Many of us help with the grieving family members. So don't leave your colleague to deal with this alone. Remember, in the hospital, it's going to take all of us nurses helping with the family of the deceased patient because the families can be really large, right? And they may need several things. And so we kind of help each other out with that, right? I have also had some family members who didn't want to see their loved one once they were passed. However, they wanted to be at the facility as a family unit. So we set up a conference room for these family members to have a secluded place to grieve together. And then we'd go in there and just, reminisce with them and help them through the grieving process, right? That's part of our job as nurses. Okay, this is the end of this chapter.